Kaladhar?
Sir.
We're good to start, sir.
Okay.
Yeah, please go.
Yes, sir. I'm start. So, good evening, everyone. Welcome to our Tuesday masterclass critical care masterclass webinars from the Department of Critical Care Medicine, Yashoda Hospitals. Here, the students present the live case scenarios of their ICUs, and they get exposure to varied, very senior expert examiners in the field of critical care medicine. So most of the students that given feedback, these sessions are very useful in practicing their critical care medicine, and even during exams, very much they review these sessions. So we are almost conducting these sessions since more than 3 years. And Dr. Venkat Raman Kola sir is the mastermind behind that, and he pushes us to do regularly these sessions. So for today's session, I welcome Dr. Yatin Mehta sir. Sir, I can say sir is a doyen in the field, and he has contributed a lot sessions and research across research also. Sir is very much involved. We are privileged to have you on our platform, sir. Welcome you on board, sir.
Thank you.
And sir is chairman, Department of Medanta Institute of Department of Critical Care and Anesthesiology, Medanta The Medcity, Gurgaon. So welcome you, sir. And I welcome another speaker, Dr. Tapas Kumar Sahoo. So he is the Associate Director and Head Department of Critical Care at Medanta, Ranchi. And he is very much involved in critical care nephrology. So he's very proactive and conducts a lot of sessions in these. I think he will be joining in a bit. So today's the topic of discussion is cardiogenic shock and mechanical circulatory devices. So this is most common entity that we come across in the ICUs, where the etiology may be different, right from acute myocardial infarction to simple peripartum cardiomyopathy. Nowadays, so many dengue cases, we are getting myocarditis and all, where they land up in cardiogenic shock, and it becomes a very tough situation, and knowing about this is very important. So to present this case scenario, I welcome Dr. Rajesh and Dr. Srivignesh. Both are DrNB students in the Department of Critical Care Medicine at CARE Hospitals, Banjara Hills, Hyderabad. So Dr. Rajesh and Dr. Srivignesh, please, you can start your...
Dr. Kaladhar.
Raman sir, yeah, please. Yes, sir.
Yeah, so Dr. Tapas is on board. Welcome you, Dr. Tapas, a seasoned academician, has been a part of all the postgraduate academics. Thank you, Tapas, for joining us from abroad in your busy schedule. You can switch on your camera, Tapas. Welcome you on board. Tapas, can you hear us?
He's joining as a panelist now, sir.
Hello. Good evening,
Tapas,
sir.
welcome on board. Thank you for joining us.
Good evening, Dr. Venkat. Good evening, Jatin, sir. It's always a pleasure to and also a privileged moment to have the session with you. And welcome, and good evening, Dr. Kaladhar also.
Yes.
Yeah, Yatin sir, from our student days, we have seen you as a Dion, and you have been a source of inspirations for many of us from our younger ages. We look to you for everything, and we inspired by you over the last 2 to 3 decades, sir. Thank you for doing that and being a part of it.
Thank you, Venkat.
Please go ahead.
Yeah, Dr. Rajesh, yeah, you can start your presentation. You're muted, Rajesh. Rajesh, you're muted. Please unmute yourself.
Am I audible, sir?
Yeah, yes. Please go ahead.
First of all, I'll thank Dr. Venkat Raman sir and
There is a bit disturbance, Dr. Rajesh.
allowing
Rajesh.
I think there is another system logged in Zoom. Can you please turn log out from that system? That's why it is just generating this radio sound. Dr. Rajesh.
Other systems, sir. Yes, sir. Yeah, one system, sir.
Yeah, now you can go ahead. Yeah.
Is it audible, sir?
No, now it is audible.
Yes, yes, sir.
Yes, sir. So I'll start my presentation, sir.
Yeah.
Thank you.
Your audio is the problem, Rajesh. There is some problem with your audio actually. Video and presentation are good. They are visible and good, but audio there is a bit issue. Can you move to this side to the Srivignesh place?
Sir, is there any other system like mobile or a laptop from where you have logged in this meeting? If two systems are together logged in the same meeting, then this noise will come.
Okay. Mobile it is logging, sir.
Yeah, please log out from there.
Please log out from.
Is it audible clear, sir?
Yeah, now.
Yeah, much better. Yeah.
Okay. Thank you. Cardiogenic shock. And here is a.
No, again it is an issue actually. No. Rajesh, again it's an issue with your audio.
Logged out from that mobile phone? Did you logged out from that mobile phone? Is there any other nearby devices which are connected?
We have logged out from the mobile phone, sir.
So you speak now. Is it clear now? You speak out.
Yes, am I audible, sir? I am audible.
Yes, the sound is better. Yeah.
What? But once you are going to that screen, why it is disturbing? Now you talk.
I'm not in full screen, sir. Am I audible now, sir?
Yes.
Yeah.
Can I go to full screen?
Yeah. No, you don't go to the full screen. I think once you go to the full screen, it is not disturbing. You can.
Yes.
Okay.
Yeah.
Is it audible, sir?
Yes.
Once I am sharing, there is.
Yeah.
So we will share.
You do it in
Can
off
you share?
screen. You will do it in off screen. Yeah.
Okay. Then I'll.
Or otherwise, Tirthankar, do you want to share the PPT?
Sure, I will share the PPT.
That's better. Yeah.
Okay, relax. Okay, this is all technicality happens in exam also. Don't worry.
Is it visible?
Yes, sir.
Yes.
Okay.
Next slide.
Go forward.
Next slide.
Next slide.
Next slide. So I'll start presenting, sir. If
Yeah.
I'm audible clearly, sir.
Yes.
Yeah.
Okay, thank you. Here is a 60-year-old female patient presented with a history of chest pain, which is retrosternal and non-radiating pain. And there is no aggravating and relieving factors for the pain, and there is no variation with her respirations. And it is also associated with breathlessness. It is also associated with breathlessness, which is sudden in onset, and New York Heart Association grade 4. And she also gives history of syncope for a brief period of 1 to 2 minutes and then recovered. And it is not associated with any palpitations, nausea, or vomiting. And she didn't give any history of fever, cough, or associated with product expectoration or bilateral lower limb swellings in this. Next slide. Next slide, sir.
Great.
Going to the past medical history, she is a non-diabetic on oral antihypoglycemic drugs. She uses metformin 500 mg and also non-hypertensive on tablet amlodipine 5 mg OD. And she is a non-smoker and non-ethanolic, and her bowel bladder habits are regular. Next slide. On examination, she is a moderately built lady, well conscious and oriented to time-place person. Her GCS is 15 by 15, and when you examine her vitals, heart rate is 200, is tachycardic, and she has hypotension with SBP of 70 by 40, and good normal blood sugar.
See, one second. I'm going to interrupt whenever I think. When you
Yes,
talk
sir.
about blood pressure, always say patient supine or sitting, right arm, left arm, right leg, left leg, whatever. So be clear about that. See, you have to take the steps of the Hutchison and Hunter. Do it properly, do it system-wise when you talk about examination.
Yes, sir. Her blood pressure is measured in the right arm and in sitting position with NIBP. Her blood pressure is recorded around 70 by 40. And she is hypoxic with the saturation. Same slide. Go back, sir. Back. Previous slide. Yes, sir. So she is hypoxic, maintaining around saturation 86%, even with 10 liters of mask with Hudson face mask. And she is also tachypneic with respiratory rate of 39 beats per minute. And she also complains of retrosternal pain, which is her score is around 5 out of 10. And on general examination, she has a cold and calm peripheries, and CRT capillary refill time is around 5 seconds, and there is no pallor or cyanosis clubbing interest or no bilateral pedal edema, pitting edema, and JVP, which was measured, is normal. Next. So coming to systemic examination, on cardiovascular examination, first heart sound and second heart sound are present with no murmurs.
No. See, when you can jump through, but when you present in an exam, you will have to go system. You first don't start auscultation immediately. You will have to say that on examination there is nothing on the anterior chest wall, the pulse, the apical pulse is visible or not visible, nothing like that. You can jump through just now. It's okay. But properly, when you are presenting in an exam, this is not the way. You should do it systematically properly. Okay? Yeah.
Yes. So the chest wall is anatomically normal, and there is no moving. Chest wall is moving equal on both sides, and on inspection there is no enlarged veins or any chemotic patches on the anterior chest wall, and coming to the auscultation, there is S1, S2, first and second heart sounds are present. There is no other heart sounds, and there are no murmurs, and no bruise felt in any other peripheral arteries, and the arteries were feeble, and there is no radioradial or radiofemoral delay. Coming to the respiratory system, again chest wall is normal and moving equally on both sides, and on auscultation there are bilateral air entry which was equal, and there are bilateral coarse crepitations which are increased on the basal. And coming to the abdominal examination,
See, no. I'm sorry. See, you have to say if the patient is. You said the respiratory rate is high. It was 35 or something like that.
yes,
You have to say, is he using accessory muscles for respiration or not? Is he listening? Is he? So you have to mention that. Patient is looking comfortable, not comfortable. That has to be mentioned, okay?
Yes. She's tachypnic and she's not able to produce spell a sentence, complete her sentence, and so and coming to the she's also using her accessory muscles for breathing. And per abdominal examination, which was soft, and abdomen is non-tender, and her bowels and suppression. And CNS examination, her higher mental functions are normal, and she was drowsy, arousable, and no focal neurological deficits were found on examination.
Yeah.
Next slide. So as she is tachypnic and also has respiratory distress, we have started her on NIV support with 100% FiO2, and ECG, which was taken within 10 minutes, which was showing ST elevations and
See,
T
again.
Yes.
NIV with 100% FiO2 is not good enough. You have to mention what is your IPAP and what is your EPAP. And what rate have you fixed it at? I mean, you have to specify this thing. You are appearing in a critical care exam. You know, this is not a general exam. Okay.
Sorry, sir. And we have supported her with 14 pressure support and fixed her NIV PC control, sir. We fixed the rate of around 24, sir, to match her respiratory rate, and also PEEP of 10, sir. With that, her rate came down with the NIV, and we have done a ECG, which was showing a normal rate and normal sinus rhythm with the ST elevations in the and T inversions in the second, third, and the AVF leads, and also the ST depressions in the V2 and V3, and T inversions from V4 to V6. And bedside 2D echo point of care 2D echocardiography was done, which was showing left ventricular regional wall motion abnormality in the inferior and posterior wall territory, and moderate LV dysfunction on eye volumes method, and grade 2 diastolic dysfunction, and mild MR and mild TR, and right ventricular systolic pressure measured around 40 mm of Hg, and IVC diameter which was dilated and not
No, that's not good enough. IVC is how much?
2 centimeters, and IVC around 2 centimeters dilated, and is not varying with the respiration, more than less than 50% variation with the respiration. And we have also done a bedside.
Grade 2 LV diastolic dysfunction, how did you assess?
Sir, we have with the phase study probe kept in the apical apex of the heart with the 4-chamber view, and pulse wave Doppler, which was kept at the opening of the mitral valve. And first we will switch on the Doppler. So we'll have a waveform which shows early diastolic filling E, which is more, and also there is a diastasis followed by we can have a late filling with the atrial kicks A. We can see E and A, and it will be very similar to the normal function. And next we have to differentiate and go for the tissue Doppler, sir. The tissue Doppler will switch on and keep the tissue Doppler in the mitral annulus, medial septal side, and we will switch on the Doppler.
Okay, good enough. Go ahead. Good enough. Go ahead.
Then we have examined the ultrasound of lungs, and ultrasound showed bilateral B profiling, and with no evidence of efficiency. And APG showed metabolic acidosis with hyperlactates levels of 3.6 millimoles per liter. Next. So we send blood investigations.
Did you visualize the pulmonary artery or RVOT?
RVOT, yes, sir. We calculate the right ventricular systolic pressure. There is mild TR, and it's around 40 mm of Hg.
No.
And
for main pulmonary artery, you should mention, because you are talking about a patient with chest pain.
Yes, sir.
Right? So you have to, rule out pulmonary embolism. Also.
Yes, sir.
Yeah. Despite the ECG changes. Because the ECG changes in the inferior wall can happen because of a P also. Secondary to P, right? Ventricular strain pattern will appear.
Okay, sir.
You understand? You have to mention that grossly you could not see any major thrombus in the main pulmonary artery. Okay.
There is no gross clot. No clots in the right pulmonary artery, and there is no severe tear which rules out pulmonary embolism. And coming to the blood investigations, her high sensitivity troponin I is around 50,000 picomole per ml, and NT-proBNP was also sent, which was some 300 picomoles per ml. And complete blood picture was taken, and hemoglobin is 14, and there is a leukocytosis 18,000 cells per cc, and platelets which are 3.3 lakhs, and her RFT is abnormal with creatinine of 1.62 milligram per deciliter, and liver function there is transaminitis which is abnormal, and where the SDO tends to be values are 89 and 566, and also the INR is normal, no coagulopathy, and the hepatitis is also normal, and her serum electrolytes are also checked which were normal, and chest X-ray which showed bilateral non-homogeneous opacities extending from hilum to the periphery, and there are bilateral CP angles which are normal, and cardiothoracic ratio which is normal, and there is no cardiomegaly in chest X-ray. CT brain was done in view of syncope, so which is showing only small ischemic changes and no other abnormalities of stroke or hemorrhage. Next. This is the ECG, sir. There is a Q wave formation along with ST elevations in the lead 2-3 AVF, and there are reciprocal changes in the V2 and V3 ST depressions more than 0.5 mm, and T inversions in V3 to V6, and normal sinus rhythm. Next slide.
Okay, just a second. Now, because she has history of syncope, you did a CT scan of the head, correct?
Yes, sir.
Would you like to do something else before CT scan?
We can do bedside. We would have done carotid Doppler, sir.
Yeah, at least the Doppler should have been done, right?
Yes.
Should do a Doppler with that. Okay.
So because of hypertension, we initiated on noradrenaline, and her vitals improved, and her heart rate improved to 92, and her BP stabilized with measured on measured with NIBP on the right arm in sitting position on 30/80 with NORAD of 0.3 mics per kg per minute, and her respiratory rate also.
Rajesh, just interrupting. Why you are saying again and again in sitting position when the blood pressure is so low, patient is having history of syncope and respiratory rate is 39 with high NIV support. So you are not supposed to measure the blood pressure in sitting position. Okay. It should be in like a proper position, in supine position. Rather, it should be head low. But yes, as the patient is in respiratory distress, at least in the semi-recommend position.
Because of
Not interesting. He's right. Yeah.
orthopnea.
No.
Yes,
Also, what is your preliminary diagnosis? Provisional diagnosis.
Yes.
Provisional diagnosis, my provisional diagnosis could be acute myocardial infarction or with ADHF, acute decompensated heart failure, causing acute pulmonary edema, and shock. It's probably cardiogenic shock.
Yeah, cardiogenic shock. What is the primary pathology in cardiogenic shock? Why do you think the person has low blood pressure or low perfusion?
The primary pathology in the cardiogenic shock is decreased cardiac output, where the decreased.
Fine. So you stop there.
Yes.
What does noradrenaline do?
The noradrenaline will increase the mean systemic filling pleasures.
That's
and
what it
also,
does.
Yes, sir.
It's a very poor inotrope.
Yes, sir. Only poor.
You are treating it symptomatically by increasing the blood pressure. I'm not disagreeing with administration of noradrenaline when the systolic pressure is 70, but that is not the first drug which you should be administering. You need something to kick up the cardiac output, you know. I have seen your presentation. You have throughout presented only non-adrenaline. You kept on increasing the dose and added vasopressin.
Yes, sir.
The primary pathology is low cardiac performance, low cardiac pump activity, which you are not treating. You are just trying to increase the blood pressure. And you think blood pressure is perfusion. It is not. I agree that you have to maintain the mean arterial pressure over 65. But this is the fundamental thing which most of the critical care doctors must realize, that there is a difference between septic shock and a cardiogenic shock. Cardiogenic shock, you will have to give something to support or increase the cardiac output, in addition to vasoconstrictor if is required. So I am not saying your norepinephrine is wrong, but you should have added something else additionally, maybe dobutamine or whatever. Okay. That is very important to realize that.
Yes, sir.
I totally agree with Yatin Mehta sir, that if at least there is a problem with the cardiac output, if you start first with the dobutamine, maybe you don't need the noradrenaline also, because the problem is cardiac output, ineffective cardiac output. So if you are supplementing with the inotrope, better you have to they avoid the vasopressor, because vasopressor is actually creating problem if you are not increasing the inotropy action.
Sir, I have one doubt, sir. There is a vasodilatation with the dobutamine, so which can worsen the shock.
Yeah,
if
so
we are not-
you may have to increase your
Yes.
norepinephrine dosages, whatever, but you'll have to
First
supplement
one.
it.
Yes, exactly.
So as the patient was not maintaining well with the NIV with maximum support, patient was planned for elective intubation with NIV support.
Now also, sorry, this is a common mistake which everybody does. This is not elective ventilation. This is this is indicated. Mechanical ventilation is indicated. It is not elective. Elective which you preempt or which you do it before it is necessary. This is not necessary here. Patient is still hypoxemic on NIV. He needs a mechanical ventilation.
Yes.
Okay.
Emergency.
Yeah. So you did the right thing, but it's not elective. It is indicated.
Yes. So we have pre-oxygenated with same NIV with 100%, and we have sedated her with etomidate 10 mg, and also rocuronium is used for relaxation and muscle relaxation, and intubated with 7.5 size internal diameter endotracheal tube, and kept connected to her mechanical ventilator. And all through the intubation it was stable, and post intubation the vitals are stable, sir, with same amount of not increasing the amount. Next. So our chest X-ray, which turned out to have this picture, sir, with bilateral non-homogeneous opacities extending more from the hilum, and our CP angles, this chest X-ray CP angles were clear, evidence of no pleural effusions. Next slide. So with this, my provisional diagnosis is acute STEMI, most probably inferior wall STEMI, with moderate LV dysfunction, acute pulmonary edema with type 1 respiratory failure, requiring mechanical ventilation, and cardiogenic shock of sky grade C, Society of Cardiovascular and Angiography and Interventions, grading grade C, and requiring moderate dose of vasopressors and inotropic support.
So, Dr. Rajesh, just hold on. Can you tell me what is the most often LV wall involvement in a patient with cardiogenic shock? Is it inferior wall?
Most common is left anterior teres.
Anterior wall.
Anterior.
Anterior wall, not inferior wall. And can you tell me the clinical definition triad of cardiogenic shock?
Dr. Tapas, there is a bit audio clarity is the issue.
Okay, so am I audible?
Yeah, you are audible.
You're audible, but your voice is
Okay.
So mostly
yeah,
the
but we can
headphones.
follow anyway.
Now is it audible better?
Yeah, it's very good now.
Yeah, better.
So, Dr. Rajesh, can you tell me the clinical definition triad of cardiogenic shock?
Definition, any cardiac failure causing hypoperfusion of the and end organ dysfunction. And I mean, research definition shows systolic blood pressure less than 90 and MAP of less than 60 at least for 30 minutes, and there is acute drop in the baseline.
Madam किधर है?
Acute drop
Like-
from the baseline of 30 mm of Hg and sustained more than 30 minutes is
That is
considered as
clinical triad is like no three things you have to tell. One is
Yes, sir.
ineffective cardiac output, which you have already mentioned.
And,
There has to be tissue and organ hypoperfusion, and there
Okay.
has to be normal or elevated cardiac filling pressures, resulting in congestion. So these are the three most important things that consists of the cardiogenic shock. Now tell me one thing: can cardiogenic shock present with hypoperfusion even in the presence of normal blood pressure?
Yes, sir. Mere presence of normal blood pressure doesn't mean that there is perfusion, sir. So even with high blood pressure, the capillary refilling time will be low. Means that and high lactates, where there is a
What is the SKY classification?
SKY classification is a Society of Cardiovascular and Cardiovascular Angiography and Intervention Society classification. It classifies into A to E, sir.
Grade 1 it will be normal tension and normal perfusion will be there, sir. And grade 2 it will be normal tension and hypotension and normal perfusion will be there. And grade 3 and where this patient is like hypotension and hypoperfusion will be both be there. And in case of grade 4 there will be worsening hypotension and worsening hypoperfusion. In grade 5 it will be extreme case. In patient might be going to
Patient
collapse.
is in cardiac arrest. In which
Yes, cardiac
stage?
arrest.
In which grade?
E, sir. Cardiac arrest
Five.
requiring ECPR.
Okay.
Grade E.
So now your patient in its like in the Forrester classification,
Yes, sir.
what should be the proper stage?
So she's having acute pulmonary edema, sir, where the pulmonary capillary pressure will be more than 18, and also cardiac index is low. She's having hypotension. So
It is
it will be
Forrester classification 4.
Yes, sir.
Grade 4.
4, sir.
Yeah, cold
Patient
and
is
Light
cold
cold
and
and
wet.
wet.
Yes.
Cold and wet.
Now tell me, what are the phenotype classification of cardiogenic shock? And in your patient, what is the phenotype classification? Do you know anything about phenotypic classification?
Yes, sir. Warm and dry and cold and
No. Cardio-renal will be one, sir, and cardio-metabolic. And first one, another third one,
Non-congested.
non-congested.
Key classification as per one system, that is non-congested, cardio-renal, cardio-metabolic. So cardio-metabolic, it would be the liver would be involved. Multi-organ dysfunction syndrome will be starting. So your patient is also showing the lab findings of SGOT, SGPT rising. Then there is also creatinine is high, 1.6. So patient is in the cardio-metabolic. There is another phenotypic classification where it would be left ventricular primary, right ventricular primary, and biventricular primary. Like no, both the ventricles should be there. There is another classification where the etiology is the phenotypic classification, like acute myocardial infarction. If it is associated with that, it would be one phenotypic classification. There would be also acute decompensated cardiac congestive heart failure. That could be also one of the primary etiology. So that is also another classification of your cardiogenic shock. Mehta sir, anything sir?
No, that's fine. Go ahead.
Okay. So now tell me, what are the common causes of cardiogenic shock?
Most commonly, we'll have acute MI with cardiogenic shock is the most common finding, and also you can have another type of cardiogenic shock where there is acute decompensated heart failure causing cardiogenic shock, and different etiologies with acute myocarditis, secondary to viral or other conditions, and a postpartum cardiomyopathy presenting with cardiogenic shock, and also acute right ventricular failure secondary to embolism or and acute tamponade causing obstructive shock and causing cardiogenic shock.
Post cardiac arrest, cardiogenic.
Post cardiotomy,
Cardiac stenting also.
So always in the examination, have a structure in your mind while answering. So if you will be like asked this type of question, if you start with a structure in your mind, like first acute, decompensated, chronic. Now there should be another way of answering myocardial, pericardial, valvular, and conduction. And you have already answered most of the etiology, but always have a structure while answering so that you will not forget. At least the examiner would be so confident that yes, this candidate knows about most of the things rather than like no answering in like arbitrary way. He is answering in a stepwise fashion. Yeah.
Thank you. We can next slide.
Okay.
Next slide. So this patient was given a loading dose of dual antiplatelet therapy with aspirin of 325 milligrams and ticagrelor 180 milligrams and statin, that is atorvastatin 18 mg, and anticoagulation 5000 units bolus was given, and unfractionated heparin, and then followed by infusion. So this patient is unstable, so the central line was placed, and arterial line was placed in view of cardiogenic shock, class C, and also
Your arterial line should have been placed earlier. Also the central line, because you are giving very high doses of norepinephrine through a peripheral line. You are allowed to do that for a short period of time.
Yes.
But I think that should have been done earlier. And normally you give it before you heparinize the patient. Although it's not a huge dose, but still it does make sense. Otherwise, suppose you puncture the artery or it gets a big hematoma, whatever. So it makes more sense to put a central line and arterial line earlier.
we continued with intravenous heparin for 800 units per hour infusion, and patient has persistent shock in spite of dual vasopressor support with progressively increasing doses of both noradrenaline and vasopressin dose, and the patient is also showing being oliviric. Next slide.
See, norepinephrine of 0.8 mics units mics per minute is a huge dose. Your vasopressin should have come in earlier.
Yes.
Okay. Also, dovitamin you still not started. Anyway, go ahead.
Next slide. So with this scenario, patient was planned to shift to the cath lab for the placement of higher BP with the left femoral axis, and started with highest augmentation, maximum augmentation with complete support of 1:1. And also following the placement of higher BP, coronary angiogram was done, which showed LAD for mid 50% stenosis, astroproximal, and 40% mid stenosis, and LCX, which is non-dominant in organ, and also distal occlusion of 100%, and RCA showing 99 proximal and 99% mid observed, and it's a double vessel disease for which a primary PCA was done. The garoting stents was placed in RCA as well as LCX. This picture showing the initiation of IABP, and also we have checked the placement of IABP by taking a 1:1, changing from 1:1 to 1:2, and looking for the waveforms appropriateness, and then we continue with the IABP. So the next. Okay.
See, looking at go back one slide, please. Go back. Yeah. No, your systolic pressure. No. Let's look at the IBP trace. Yeah. Your systolic pressure is 142. You don't need such high perfusion pressures. You are on very high doses of 100 vasoconstrictors. I think you should come down on your vasoconstrictors. So you must mention it to the examiner that we started tapering the norepinephrine and vasopressin at this point of time. Okay.
Yes. After starting IABP, we can be able to come down on the doses.
Yeah.
So before that, we confirm the chest X-ray position also. Next slide. Chest X-ray position, and there is a marker at the tip of the balloon just beside the diversion of carinus, and also
No, your tip of the balloon is above the carina. So it is pretty close to your subclavian artery. I would have pulled down the balloon by a couple of inches. you are augmenting the pressure, the arterial trace, you could see the augmentation, but it's a little too. Hello, yeah. So what happens if the balloon is too high?
It could obstruct the left subclavian, sir, which was originating just below the aortic now.
It can obstruct the carotid also.
It can
obstruct the carotid also.
Yes, sir.
So left ischemia and also cerebral hypoxia will be the risk.
Yeah, correct. All right. So pull down the balloon, I would have done.
Yes.
Okay.
Next
And
slide.
why did you put the left interjugular vein?
So left interjugular vein, as the patient is oliguric, she was planned to have dialysis, sir. So the right side we
You
will
were
have
leaving the right side?
good flows for them.
That is very considerate of you, but I would have put the right, because I'll tell you why. It's an inferior wall myocardial infarction. Inferior wall myocardial infarction is known more not for cardiogenic shock, but for heart blocks.
Yes.
So this patient has a high possibility of going into blocks. So you may need to use the transvenous spacing. So putting a section is something like that normal regular CV catheter, I would have put in a 7.5 French sheath, so that I can put in a transvenous spacing if required.
Okay, sir. This ECG post PTC. This is ECG. We have QS with decrease in the ST elevations and also left out with the T inversions with the inferior wall leads 2-3 AVF, and also ST depressions are also improved in V2 and V3. Next slide. And renal replacement therapy was initiated after placing HT sheath in the right interjugular vein, and in view of worsening renal function test as well as oliguria. And initially, CRRT was advised to the patient, but in view of financial constraints, we could able to do sustained low efficiency dialysis. And following that, IOBP, which was continued with the 1:1 support, and shock started improving, vasopressor requirements came down. And on day 3, IOBP was weaned off. Initially, it was kept to 1:2 support for 3 hours and observed for hemodynamic stability. And also following that, it is came down, tapered down to 1:3 support for 2 hours and then removed. Anticoagulations.
Okay. Now stop. See, you are primarily treating cardiogenic shock. The indications for pulmonary artery catheter, although it is not highly appreciated in septic shock because of whatever reasons it may be, but in cardiogenic shock is the only, I would say, almost absolute indication for a PA catheter, if you have the expertise and facilities to do that. Now, if you have the expertise at the center where you can do primary PTCA and you can put in a balloon quickly, and you can do all this, I see no reason to put in a PA catheter. Because you're trying to treat a low cardiac output status without any monitoring on cardiac output. It's not even done non-invasive cardiac output monitoring. There's no form of cardiac output monitoring which you have done. In present times, that is not. Even if you don't want to do aggressive PA catheter, you not some sort of monitoring should be done. Patient is on a mechanical ventilator.
Yes, sir.
One more additional benefit of putting PA catheter is that would help us to go for the mechanical circulatory assist device also. Which type of further mechanical circulatory assist device would be put in your patient?
If you're talking about mechanical circulatory devices, obviously you cannot take the decision just on these monitoring. You'll have to have a higher degree of monitoring to be able to decide what monitoring, what device he needs, right?
Yes, sir.
Because this guy dramatically improved because he probably already was okay. Suppose he doesn't improve, then what does one do? One has to think of mechanical devices,
Yes.
right? Okay.
Next slide. Next slide. So, and meanwhile, she underwent further 2 sessions of sled, and following that, oxygenation improved, and we are able to wean off NIV support at day, ventilator to NIV on day 4, and her kidney function improved following that, and also weaned off from RRT support, which was there previously alternate days, and on day 7, and discharged her on day 10.
Heart function had improved, ejection fraction had improved.
Ejection fraction, it's same, sir, like moderate LV dysfunction.
45%.
Yes.
Okay.
Dr. Rajesh, is there any
Yes, sir.
role of thrombolytics in this patient?
Yes, sir. If our center is not a PCS center, I would go for a thrombolysis within 30 minutes. Sir.
Okay. So, what is the limitation of thrombolytic therapy if your patient is having hypotension?
Hypertension is a contraindication, sir. More than 190.
No. Hypo. You're saying
Hypotension.
hypotension, low BP.
We can thrombolyze, sir. Why? Because the cardiogenic shock, which is the cause for hypotension, it should improve after the thrombolysis.
No, like no
If
thrombolytic
you are
therapy, the thrombolytic drugs will not go to the culprit vessel only if there is hypotension. So that's why you have to first put on the inotropes, then you have to put on IBP, then your BP will be improved, and then you give the thrombolytics. But if you do not have your, like a PCI is not possible, then you can give thrombolytics, because hypotension, the thrombolytic drugs will not enter into that culprit vessel only, because the blood will not flow to that culprit vessel with the thrombolytics. Yeah.
After stabilizing.
Now tell me the pharmacologic treatment. How will you divide the pharmacologic treatment of cardiogenic shock?
As the first choice is again norelin support, and next choice will be dobutamine or atelene, sir.
No, don't go like this. First, you have to think
maintaining
about the revascularization,
Uh,
then afterload, preload, contractility, and heart rate. As sir has already told, you have to take care of all these things systematically. So for the revascularization, you have already started with the platelet agglutination inhibitors and anticoagulants. Then for the afterload, you would be taking care with the norepinephrine and epinephrine, as well as vasopressin, and also vasodilators. Now for the preload, again, if your patient allows, then you should go with some amount of crystal load challenge or diuretics or dialysis, as you have already started. Now for the contractility, first thing, dobutamine. What are the other inotropes that you can use in cardiogenic shock apart from dobutamine?
milrinone we can use.
Milrinone.
Yes.
And for the heart rate, atropine, then cardioversion, or in case pacing is required, sir has told, inferior wall is very notorious to have the heavy conduction defects. So you have to take care with the pacing. So that is the systematic approach for the medical management with the pharmacologic support. Now, what is the indication of mechanical circulatory assist device in cardiogenic shock? What is the benefit?
Indication is like when adequate revascularization and pharmacological support is given for at least for 30 minutes. Still, it is refractory shock. We have to go for the parameters like cardiac power output and pulmonary artery pulsatility index and PA pressures and pulmonary capillary edge pressures and also right atrial pressures, sir. And if the cardiac power output is less than 0.6 and pulmonary arterial pulsatility index is less than 1, again pulmonary capillary edge pressure is more than 15, then if there is hypoxia or only cardiac dysfunction or hypoxia, if there is hypoxia also added, we'll go for VA ECMO, sir. Or if there is only LV dysfunction.
Main indication is it buys time for you, so that at least you are interrupting the downward spiral of the patient is deteriorating. So you are getting some time so that you can go for some definitive treatment. Can you classify the mechanical circulatory assist device?
Pulse counter pulsation device like IABP and axial flow devices like Impella and
Impella.
No,
pulse.
don't name like that. You say temporary device and permanent device.
Permanent device.
And then you can go into it. Huh?
Temporary device like IABP, Impella, and tandem heart, and the permanent device like more durable mechanical circulatory devices or
No, ECMO also comes under temporary device. No?
temporary.
The ECMO will come under temporary device.
Yes.
Or else you can divide as continuous flow pump, pulsatile. In pulsatile, it will be IABP. In
IABP.
continuous flow pump, again it is divided into axial flow
Axial.
and centrifugal flow. In axial flow, it is Impella. In centrifugal flow, it is tandem heart and VA. Clear?
Centromeg. Yes.
What is the risk stratification score that is normally followed up in cardiogenic shock? Do you know any risk stratification score?
Stratification.
IABP shock 2 score. Do you know?
Yes.
Shock 2.
Okay. So it is normally derived from the cardiac catheterization, like the variables, and it comprises of 6 variables. I'm not going into detail, but you have to remember the risk stratification score. What is the role of echocardiography in cardiogenic shock?
It can differentiate between obstructive and also whether it is there in the when there is a dysfunction in the contractility or only right ventricle or both the right ventricle and left ventricle.
To diagnose the cause of the cardiogenic shock. So from either it is myocardial, you will know the contractility or obstructive. Obstruction, we will know if there is pericardial tamponade or anything is there, and we'll go for that. As I said, the pulmonary artery, if you see, then there will be a pulmonary embolism will there. It might be because of cardiogenic shock.
Tamponade is not obstructive; it is restrictive.
Yes.
Okay.
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 Restrictive. Okay.
So it would help us like to assess the overall systolic function, regional wall motion abnormality, then rule out any mechanical cause of shock. In that, everything would come, like your papillary muscle rupture, ventricular rupture, free wall rupture, all the complications of acute MI, and then also diagnose the RV dysfunction. Right. Now you told about IABP. So in examination, the examiner would be asking a lot of questions about IABP.
Yes, sir.
So starting from the hemodynamic effects of IABP, can you tell me at least 5 hemodynamic effects of IABP?
Yes, sir. So this IABP, which was getting inflated during the diastolic part of the cardiac cycle, will decrease the afterload on left ventricle. Left ventricle is supposed to work against the aortic pressure, to open the aortic valve. So when there is a inflation of the IABP balloon, so it will increase the diastolic pressure and increases the coronary perfusion, and also decreases the afterload on left ventricle. Both decreasing afterload on the left ventricle or decreasing the end-diastolic pressure will increase the coronary perfusion pressure. So the coronary perfusion pressure is increased, and also left ventricular unloading is happening both at the same time. These are both advantages.
So overall, it will decrease the myocardial oxygen demand, sir, and ischemia will be decreasing, and it will stop the spiral, which will happen in cardiogenic shock.
At what point in the cycle does it supposed to augment? Inflate the balloon?
Inflate when
Inflate
the
will be
aortic
done.
valve closes. When aortic valve closes, it's supposed to inflate.
Yeah. At what point in the cycle? Upstroke, downstroke? Huh? Arterial trace, upstroke, downstroke.
Arterial trace, it is downstroke at the just after the aortic notch, sir.
The dicrotic
Just after the dicrotic. Just
Yes.
after the dicrotic.
So in ECG,
If
it will be PT interval.
If your inflation of the balloon is earlier, then what happens?
If the inflation of the balloon is earlier, then the waveform is shown just above the augmentation will start just above the dicrotic notch, and there will be loss of a classical V shape, and also this will cause additional load on the left ventricle
It will be
to pump
detrimental
against
to the left
against the afterload, increased
It will be
afterload.
deleterious in shock where there is already decreased perfusion and cardiac output. So it will be against
What is the
wheels
volume of
we
the
are using.
balloon?
40
What is the
ml.
volume of the balloon?
40 ml, sir.
40 to 60 ml. Yeah.
40
And
to
what
60.
gas is used?
Helium gas.
Helium will be
Insulated? Why is helium used?
Helium or
It is
carbon.
inert gas, and also it has a low viscosity. So even when we are giving,
Very
it
good.
will less turbulence because of linear flow. So it will be better.
Can be inflated and
Very good.
deflated fast.
Yeah, fine. What happens if it is inflated too late?
If it
Inflated
too late, then again it will be decreasing the efficiency, so that the duration of diastolic
So-
inflation will be decreased,
will
and
not
it will go
So it
into
won't
the
be
systole.
as effective as
Yes.
it is done.
diastolic time is underutilized.
What will you do if the patient is in atrial fibrillation
We'll change
or in
to
heart block?
there is a in atrial fibrillation there is a mode, sir, for atrial fibrillation. So in the auto mode it will inflate after it will deflate after every RV.
Auto mode is not to be used except for CPR.
Okay.
Okay. So in
So
case of arrhythmias, you put it from instead of the ECG, you put the
Arterial.
trigger as pressure.
Okay.
Okay, sir.
Okay.
True.
I think they have covered most of the things. So Dr. Venkat and Dr. Kaladhar, if
Yeah.
Yeah.
Yes, sir. Yeah. So regarding actually IABP, I think there are some questions. So IABP, role of IABP even after like IABP shock to trial, most of the times even exams is being asked. So in cardiogenic shock, what do you think, sir? What are your views?
See, IABP shock trial in the absolute numbers were negative. That means it did not show any long-term benefit. Okay. But if you do the sub-analysis of the subgroup of cardiogenic shock, then it did improve the mortality. So I think in cardiogenic shock, there is no question that it is going to only, but it has to be used only if you are going to do an intervention. That means if you have the facility to correct perform the revascularization by whatever means.
Yes, sir. And Dr. Tapas, yeah, basically most of the times what we like can practice apart from IABP, the most common support mechanical circulatory support device that for cardiogenic shock especially is the VA ECMO, but because that can be somewhat better possible compared to Impella, LVAD and all. So especially the cases even like young patients coming with peripartum cardiomyopathy and young patients and dengue, especially coming with the myocarditis or some scrub coming with myocarditis. What do you think when we have to initiate, and how do you think the prognosis is going to be in these type of patients?
Exactly. And also it will take care of the respiratory part also. So apart from the cardio part, so this is the best advantage of like the VA ECMO is also respiratory. So that is an added advantage. Yeah.
See, first you would put in a balloon and then obviously revascularize. And if still not getting there, then VA ECMO will be the next thing to do. Because VA ECMO, according to the also database, has a mortality about 40%. Respiratory ECMO, that means VV ECMO, has a lower mortality.
Yeah.
So you will use it, yes, obviously, before any other mechanical devices, but after balloon, you should go for a VA ECMO
Yes.
in this sort of patient.
Yeah. Yeah, especially the patients who are coming with cardiogenic shock, and if there is a sepsis component added, this causes some dilemma, especially choosing vasopressors and fluid resuscitation part and all. So a tricky situation. So which component is more and which component is less? So what are your tips?
VA ECMO in sepsis is a bit debatable question. Okay? But people have used it, and it's a weak recommendation. You can use it as a last sort of resort. But the results are not as good in sepsis with VA ECMO. VA ECMO would primarily be for cardiogenic shock without sepsis, I would say.
And
But for instance, for myocarditis you talked about, VA ECMO would be a very good thing to use.
Yes.
yes,
Arteries are normal. So that would be the or in Hyderabad don't get it, but we get it in North India. We get a lot of this aluminum phosphide poisoning, and they would benefit
Yes.
VA ECMO because the transit myocarditis will recovers.
correct. And regarding vasopressors, Dr. Tapas, yeah, most of the times the debate goes on like sometimes when shock is profound and the first line agent to be chosen as Noradrenaline, when to start dobutamine is always a debate. Most of the people say it is severe shock, even though the contractility is less, we don't start the dobutamine. What is your say on that?
So I will prefer to start with dobutamine and like your norepinephrine, both together. So because one thing would be taking care of the inotropy and one thing would be for the low blood pressure resulting from the vasodilator action of your dobutamine. So both the two things to be given simultaneously. If you are still not able to reach to the blood pressure, then you can add to the vasopressin. So that should be the way. Yeah.
Okay. I think we have discussed almost everything, sir. Dr. Yatin, sir, especially for the students, what do you think during exam? What are the tips that you will give, sir, to them how to like present and
You
how better they can?
present the cases more in proper methodological, like you would present a medicine case. Okay. Also, history also should be slightly more detailed than what you presented it with. And stepwise, you should know all the classifications, all the severity degree, how do you grade them of cardiogenic shock, what is the primary pathology of cardiogenic shock, what are you knew the main mechanical devices also to be used. But again, what inotropes to use in these sort of patients, you did not mention levosimendan, it's available in India. So after Milinon, you must mention it. Just because we don't use it so much in, we have such a tremendous fixation for sepsis that everything is around sepsis for most of the critical care physicians. So I would use a PA catheter in this patient. I would use a dobutamine along with the other inotropes if required. VA ECMO if required. ECMO also you must as students you should know only two studies. For any questions on ECMO, you should know only two studies. One is the original Caesar trial, which was in Leicester. Okay, I'm not going to tell you in detail, but you must read it up. And then Eolia trial. These are the two main papers which you should know about. Regarding uses of PA catheter or IABP, you should know the shock 2 trial. You must know about more in detail than what you mentioned. Testo trial you should know about. So these are 2-3 important trials which you should know about. PTCA, which PTCA do to which vessel? Would you do it to culprit vessel or will you do it to all the vessels which are required?
According
In
to
this case, the culprit vessel patient was in cardiogenic shock. Yes, so you did it in both the vessels. It's not necessary. It could be staged. So you should have done it on the culprit vessel, and there is an EJM paper on that. That culprit vessel is as good as this thing with lesser mortality actually. So that makes more sense. Just you should have done the RCA and come out, done that maybe at a second sitting or whatever. So that is how it should be. So it is a little weak from the normal. I find other critical care guys also a little weak on the cardiac side. So I think maybe they should be posted for a little longer on the cardiac side.
Dr. Tapas, you conduct a lot of sessions, especially DrNB preparatory courses, which are very sought after, even our students attend. So what do you think the tips, especially during practical exam, you want to give?
So, Dr. The Rajesh and Dr. Srivignesh. So, few things for like examiners always have the things that you know as the first things you are speaking in the examination, and also always have a structure in your mind. Don't just answer haphazardly. That is point number 2, and know about the theory part very confidently, So when you are answering in the examination, definitely the examiner would be taking you to the evidences, taking you to the recent guidelines, the classification. So always keep all the things in your mind, because in cardiogenic shock, I will be definitely asking you the classification. I will be definitely asking you the management protocol, management plan, then the recent guidelines, then the risk stratification scores, then the indication, contraindication of the mechanical circulatory assist devices, what we normally do in our CCU. So normally as a an attending, I am definitely expecting that you should be managing the airway protection part in the correct time. You are not taking much time for taking the decision to intubate, and you are doing the crash intubation, because it would automatically increase the mortality rate in your patient. So first things first, at least saving the patient, not doing more harm to the patient, and also taking the decision for the definitive management. So all the things you have to be keeping in your mind, and the examiner in the meantime will complicate it also. It will not be only cardiogenic shock. He will be now delivering that once you are putting the patient on IBP, now the second day patient is having fever, and your oxygen requirement has increased to 80% or 100% on the ventilator. What is going on in your mind? Patient started having bleeding. So the examiner would be trying to little bit twist the scenario. So that also you have to keep in mind. Then you have to take care of the general care, and at the end you have to counsel the family about the prognosis. You have to involve the multidisciplinary team. So all the things would be coming in your mind simultaneously, because the examiner would try to see, assess that how you have handled this patient in your ICU, in your training period. Clear?
Yeah. Thank you. Thank you, Dr. Yatin sir and Dr. Tapas, for coming onto our platform. I think it's a very good session. I think most of the students get benefited from this. And thank you, Dr. Rajesh and Dr. Srivignesh, bringing that case and presenting on this platform. And thank you, our Yashoda Hospitals team and our digital team and branding team for regularly providing this platform to discuss the webinars. Thank you very much.
Okay.
Thank you. Thank you.
Thank you.